Dear ladies and gentlemen, in the following video we present a novel technique for an implant-free, suture-only transosseous refixation technique for an osteochondral fragment at the radial head. The authors declare no conflicts of interest for the following video. After careful clinical examination, X-rays, MRI and CT scans are obtained to estimate the size, defect localization and especially integrity of the fragment. The indication whether to refixate or remove the fragment depends on the above-mentioned factors. Final indication to whether refixate or remove the fragment is made after diagnostic arthroscopy. Once the indication for open refixation is made, a lateral approach is performed. The coxa interval is identified and opened between the musculus anconeus and musculus extensor carpi ulnaris. During subcutaneous preparation, utmost importance must be paid to the posterior antebrachial cutaneous nerve. The joint capsule is carefully opened and the annular radial ligament is split to allow visualization of the entire radial head. For better visualization, a mini-Hohmann retractor can be placed around the radial neck. The defect area is subsequently debrided and the osteochondral fragment is placed into the defect. If necessary, the size of the fragment needs to be adjusted using a scalpel. After, using a K-wire and beginning at the anterolateral radial neck, two 1.2 mm drill holes are carefully placed in the fragment about 5 to 7 mm apart, depending on the size of the fragment. A bone bridge of about 8 to 10 mm at the radial neck side is retained to facilitate secure suture tying. Using a flexible loop wire, two resorbable number 2 Velcro sutures are passed through the fragment using a U-shaped technique. The fragment can now be fixed by tying both sutures over the previously created bone bridge. This method ensures a stable transosseous refixation, promoting optimal stability. No further implants are required. Following refixation, the annular ligament and joint capsule are closed using resorbable sutures. Subsequent surgical procedures, such as the refixation or reconstruction of the lateral ulnar collateral ligament, like in this case, may also be necessary. Starting from the first day after surgery, early passive mobilization and exercises are permitted. An elbow brace is worn for the initial 6 weeks. Range of motion is restricted to 0-29 degrees of extension and flexion during the first 2 weeks and gradually increased at week 3 and 4. Pronation and supination are restricted for the first 2 weeks postoperatively. Following the removal of the brace, active range of motion exercises and strengthening are recommended. If you have any questions, comments or recommendations, please contact us anytime. Thank you for watching.